adult psychiatrist. Okay, thank you. Two of you said I didn't know what to talk about when you were given the topics. In fact, it wasn't me who came up with these topics. They called me saying there's a psychiatrist, in fact, psychopharmacology meeting, and there's going to be a child psychiatry session, and these will be the topics. And because they thought that the topics will be small as the children will deal with, they gave us these topics to talk about during the day session, and I guess I'm there talking about resistance, everyone talking about children's disorders and resistance. Now I'm going to talk about resistance and solutions in adult ADHD. I don't know why in this session, but I was given this topic. If a child is not being treated, I mean, if that child is resistant, the mother, father, teacher, consultant, psychiatrist that she sees must be questioned, must be examined, because it's probably not the disease or the treatment itself that the child shows resistance, it's the family or the friends or the relatives, etc. Because families usually say, but this is a child, why are you prescribing medication to the child? But this is not the case. They say this is a child, that's what a child does. But this is not the case. Some of my friends, my colleagues in fact, used to say that you find a bunch of naughty children and you call it hyperactivity disorder. But now, of course, people come to realize that these diseases do not arise out of the blue in adulthood. They have roots in their childhood. And now they're saying there really is such a disease, isn't there? And now we know how to diagnose, how to treat adult ADHD, and today we're focusing on what to do when there's resistance to treatment in ADHD. I have quite a considerable amount of patients with ADHD. Adults, before treatment, they have experienced anxiety disorder, diagnosed with AD and depression, and they were given SSRIs for a long time, but the main symptoms didn't disappear, so these patients became pessimistic, saying physicians cannot diagnose and we don't know what to do. I have more than 20 adult patients. By adult I don't mean above 18 years, because above 18 years these are not still adults for me. I've been following them since their childhood. I'm now talking about around the age of 30. They got the depression or anxiety diagnosis beforehand, and they arrived with ADHD. There's another group who have somehow found some information on ADHD in a book or something, reading some symptoms and saying, I have these findings. Maybe I have ADHD. They benefit from this. But there are also those adults who read a book for their friends' children or for their children, and they realize that there are such symptoms still enduring in these children. And these children become adults and they are referred. There is no need to repeat what has been said. The treatment is similar to childhood ADHD, but in adults there is one difference. Psychostimulants are the first line of treatment for ADHD, but they don't seem to be as effective in adults, and the reason is multiple. One of them is there is a lack of, some of these symptoms are affected, such as lack of attention, distress, etc. But they don't work well on functional disorders such as managing time, organization, planning, etc. So we don't see immediate response as in children. The patients do not regard this as a miracle. Secondly, attention deficit seems to be the predominant feature, accompanied by forgetfulness. So due to functional disorders such as problem in managing time, it's very difficult for adults to comply with the therapy because, for example, they forget their appointments. Some of these patients say, I keep forgetting my wallet, my purse, my keys, and now I keep forgetting my appointment. So what's the point in continuing with the treatment? So the benefit rates are falling down, and because they expect the effect of treatment in a short while, and because they don't seem to have that, they discontinue. These are the biggest reasons, the biggest causes for resistance. As has been mentioned before, in ADHD, the drugs are very effective, unlike in other cases, in other disorders, but there must be some additional treatments because of the peculiarity of the disease in adults. Furthermore, we need to make use of behavioral methods, especially for time management and organization, and we should train the patient, explain to the patient what the disorder is all about. Although we do all of these, sometimes they resist or the symptoms go worse. In this case, you need to change the dosage. As Özgür just said, you shouldn't be scared in increasing the dose, and you shouldn't be afraid of reducing the dose, because if maybe the reason why it doesn't show any effect is because the dosage is too high or maybe too low. In that case, there could be resistance or treatment failure. Especially in the adult population, timing is important. So when the time will be administered, that's important in increasing effectiveness. There are the short and the long effect drugs. As you know, the long-term effects have probably 7 to 8 hours of intensive effect, not 12 hours as claimed. Adult patients can get their medication earlier on, for example at 6 a.m., and the performance distribution throughout the day is different from children, so they feel effectiveness differently than children. If you shift the time to, for example, midday, then it may also work. Furthermore, if the patient doesn't respond, you need to, of course, reevaluate the patient, revisit the diagnosis, go on to another group of medications. In adults, psychostimulants do not have an indication of adulthood, but I have some experience with atomoxetine that's new on the market. It's different than children. It has a longer effect on adults, and because anxiety is also the most frequent comorbidity, so Sclera can work in adults. So sometimes it does work to change the drug. If it doesn't have any effects at the right dose, and if you're sure of your drug, then you should resort to non-pharmacological treatment methods. There is, there's a group of people in the U.S. Writing now about the behavioral methods, not the pharmacological methods. So we should not ignore them, saying it's not a physician's job, because that's for the patient to cooperate with you, not a psychologist or not some social worker. It's not what we're used to. It's not like the CBT as we know it. It's different. It's about the fundamental dysfunctions in ADHD, and both of these can be applied at once. Sometimes one of the biggest reasons behind resistance is discontinuation due to side effects. In this case, we need to take under control these side effects. Adults can sometimes not tolerate these side effects, because in children we see headache less frequently than in adults, but in adults we have headache and sleeping disturbances, and these also result in loss of work. So we need to consider these side effects, maybe switch to another medication, or focus on non-pharmacological ways of treatment. The treatment can be very effective. All of a sudden, it seems like you start from the scratch. This happens very frequently. Then you have to change the time of medication, the hour that it's administered. You will realize that the routine is no longer there in patients. In adult patients, the time of the hour that medication is taken is very important. Furthermore, there is the progress of action, where it makes the peak and then starts falling down. If you identify a certain hour, the patient can also lead you, saying, at about 4 p.m. I see a reduction in its effects, or I have some symptoms flaring up. Maybe you can have one dose short-term psychostimulant to overcome this problem. So psychostimulants, long and short-term psychostimulants, can be administered to the patient. If not, you need to switch to another form of therapy. Comorbidities are also very frequent in ADHD. We need to monitor how they impact our treatment. Anxiety disorder, depression, and antisocial personality disorders are the most frequent ones. Leave aside antisocial personality disorder. I never touch them. Because that's I think hopeless. For male patients, I say let him go to the military service. Maybe he will recover there, but I don't think it works. But in anxiety disorder, let me say it this way: if ADHD is the primary finding, and if the primary is the primary diagnosis, and if there's primary findings showing to ADHD, and if there's a comorbidity, don't start treating all of them at once. It's usually the anxiety findings that can reduce with psychostimulants. You would then save the patient from the burden of using 2 drugs at once, and it strengthens your diagnosis as well. But if psychostimulants are not good enough to reduce anxiety, or not effective enough, in this case we can administer drugs for both of these disorders. Sometimes you realize that ADHD patients develops other morbidities, other disorders. In that case, you need to evaluate again and make the diagnosis. Tics are important for adults and males. Usually tics don't continue into adulthood, but if it does, that's a big problem. If Tourette also continues into childhood. So if it accompanies ADHD, you should not refrain from using psychostimulants because it makes tics, causes tics. You should examine the relation between psychostimulants and tics, because if you use it for a longer period of time, sometimes tics disappear. If tics don't increase and if they seem to mitigate, and if the drug for ADHD is effective, there is really no point in changing just because there are tics appearing. But if the tics are going bad, if they're worsening, you can try atomoxetine and stop stimulants. I'm saying these two only. There are some other drugs that are tried abroad, but these are the only options we have here. Using psychostimulants, we see restlessness, discomfort, hyperactivity as side effects. If you see these, don't first blame the drug, but take a look at the drug interactions. Or maybe this is a previously onset, newly aggravated disease. For example, substance abuse or anxiety. These can result in these side effects, these changes, and you can regard them as side effects due to disease. But if there's major depression, mood fluctuations, anxiety disorders, we need to analyze whether it has got to do with the dosage or the type of drug. Sometimes toxicity can result in major depression, mood fluctuations, and anxiety findings. In this case, we need to examine toxicity and findings. Sometimes adult patients say, why don't I take a bit more than the prescribed dose because I have something important to do today? Do not allow them to do that, because that may be the reason behind toxicity. Furthermore, there could be a more pronounced comorbidity, especially there could be substance or alcohol use with the medication. One can reduce the dosage of drugs, change the stimulants, make an evaluation of mood and sleep, and consider other forms of treatment if necessary. If psychosis or mania develops, stimulants must be discontinued immediately. I had such a case. That patient was 29, and at the age of 4, the patient was seen by Professor Atalay. Professor Atalay said the child is hyperactive, but the family didn't care really. and never went to the physician again. So at the age of 29, I see this patient who didn't continue their education and was unemployed, and we had the test, and it seems that this is an uncured ADHD, adult ADHD. I always ask whether they use any substances. They said there's no substance abuse, confirmed by the family, and after psychostimulants he became psychotic, and then we found his roommate in the US, and he told us that he used a certain substance for a certain period of time, because that triggers psychosis along with psychostimulants. So if there's no substance abuse, we can start psychosis or mania treatment. As a result, there are two important groups of resistance in adult ADHD patients. One of the groups is the group where there is a comorbidity or an accompanying disorder, or there are also those who cannot tolerate the side effects. The second one is the group that does not respond to any drug treatment at all. These non-responders usually are those which have some other resistant mental disorder that accompanies ADHD. There are some studies whose results have not been published. There are some prodrugs, psychostimulants, amphetamines, that sort of prodrugs, or atomoxetine can be added to these stimulants in a combined manner, may be useful in these patient groups according to studies. If there is no solution, we can cut all these drugs and start non-pharmacological methods such as teaching organization, frequent follow-up. In the US, for adult ADHD, Barkley always says do coaching, but coaching has different connotations in Turkey, so I refrain from saying coaching, but we must provide them support, training, and sort of guide the patient out of deadlock. So personal or customized support is also important. If you explain to the patient the condition and explain to the patient what can happen, what can the patient do without the drugs, I mean, there's no need for pharmacological treatment. These are the options. That sort of guidance may end resistance, I think. Thank you.